I'd like to welcome everyone to today's Public Health Practice Grand Rounds for February 2012. My name is Molly Mitchell, and I'm the coordinator for the Mid-Atlantic Public Health Training Center. And on behalf of the Training Center and the Department of Health and Mental Hygiene, I'd like to welcome everybody to our Grand Rounds for today on the HPV vaccine, public health, and ethics analysis. Before we get started with today's presentation, I'd like to just make a few announcements for those of you who are watching online. I'd like you to please take a minute to go ahead and sign in. That'll give us a better count for the numbers to let our federal funders know how many people are watching today. Also, if you have any questions at all during today's presentation, please just click on the link on your screen and you can send us an emailed questions for either of our presenters. And I'd like to also, again, for those online and for you in the live audience, to draw your attention to some of our public health practice trainings that are coming up. And they include practical grant writing, community assessment and formative evaluation, and logic models. And also feel free to look at some of our trainings that are available on our website, which include a lot of our archived public health practice grand rounds. So with that, I think I'll go ahead and introduce today's speakers. We have Drs. Nancy Kass and Connie Trimble. Nancy Kass is a Phoebe R. Berman Professor of Bioethics and Public Health in the Department of Health Policy and Management with the Johns Hopkins Bloomberg School of Public Health and Deputy Director for Public Health in the Berman Institute of Bioethics. Dr. Kass conducts empirical work in bioethics and health policy. Her publications are primarily in the field of U.S. and international research ethics, HIV/AIDS ethics policy, public health ethics, and ethics of public health preparedness. Dr. Kass co-chaired the National Cancer Institute Committee to develop recommendations for informed consent documents for cancer clinical trials and served on the NCI's Central IRB. Dr. Kass is the director of the PhD program in bioethics and health policy at the Johns Hopkins Bloomberg School of Public Health and is the director of the Fogarty Johns Hopkins Bioethics Training Program for African Scientists. Dr. Kass is an elected member of the Institute of Medicine and a fellow of the Hastings Center. Dr. Connie Trimble is double boarded in obstetrics gynecology and in anatomic pathology with specialty training in gynecological pathology. Her clinical and translational research focuses on mechanisms of immune cell homing and function in the genital tract and the development of immune therapies for disease caused by human papillomavirus, HPV. She is an NIH-funded investigator and holds 3 INDs governing the conduct of investigator-initiated clinical trials testing immune therapies for HPV-16-positive cervical dysplasia. She is the director of the hospital-based program for screening for cervical cancer and the director of the House Staff Research Program in the Department of Gynecology and Obstetrics at Johns Hopkins Hospital. In her free time, she likes to sing, to work out, and to play golf without keeping score. With that, I'll hand the floor over to Dr. Nancy Kass.
Thank you, Molly, very much, and it's really nice to be here. Let me give everyone a bit of an outline about how we've decided to organize the next hour. I'm going to start with some slides that introduce this concept of public health ethics. What is public health ethics, and how do we go about thinking through an ethics question in the context of a public health program or a new public health initiative, like, for example, rolling out HPV vaccine. Dr. Trimble will then give a lot of background on HPV vaccine so that we better understand the context we're talking about. And then I'll come back with just a couple of slides thinking through specifically a few of the ethics questions and policy questions about HPV vaccine, like whether it should be mandatory and what about boys and all that kind of thing. So I'm going to start at the bird's eye view. And I'm going to start by talking about public health, and then I'm going to talk about ethics, and then I'm going to bring them together. So the Institute of Medicine did its first report on public health in 1988 and defined public health as what we as a society do collectively to assure the conditions in which people can be healthy. And I think this definition is really rich because it talks about some really foundational values of public health, like it's something we do together. And it's something we do to set the conditions so that people theoretically can choose to make healthy choices. I'm not going to go through all of this, but I want to highlight some important sentinel events in the history of public health, because again, I think it does highlight the way in which public health goes about doing its work, which is still very true today. So one of the early pieces on my timeline is that in 1701 in Massachusetts, smallpox isolation was put into place and ship quarantine laws were put into place. So the point is, public health came in and limited people's rights for the sake of protecting the public's health. In the 1800s, Edwin Chadwick in England discovered that there was more than a twofold difference between the health outcomes, the life expectancy between rich people and poor people due to social conditions. Unfortunately, something that hasn't changed, but again becomes really relevant to what people in public health have to think about. First, vital statistics, saying, okay, what part of what public health does is collect data, whether or not people want it, collects data in order to get important outcomes, track trends in the public's health. Again, this idea of social conditions being relevant, people mapped garbage heaps and housing conditions to disease outbreaks and found there was a very strong correlation. And then in this country, a little more than 100 years ago, every state, one by one, created state boards of health that, among other things, were empowered through laws that they passed to enforce sanitary regulations and other laws. Public health has many tools at its disposal. I've talked about data collection, which comes in many forms: surveillance, vital statistics, registries. Public health also becomes proactive in doing outreach and education, basically making sure people know what are good habits, things like the food pyramid that became the food plate, the billboards you see, all of those kinds of things are a way that public health does outreach to let people know. They also do outreach in ways that maybe you would call a bit more invasive, contact tracing, epidemiologic investigations, and then there are regulations and laws. And if you will, at one end of the spectrum, public health is authorized by every state in this country with something called the police power. And that means that states are allowed coercive action under state authority to encourage educational efforts, but also to seize property, close businesses like restaurants, destroy animals, or involuntarily treat or even lock away individuals for the name of protecting the public's health. So let me switch a little bit to bioethics. Bioethics is a relatively modern name. It's a modern term. It's about 40 years old, but it absolutely has its roots in medical ethics, which has a very, very long history. Percival's Code of Medical Ethics was developed in the 1800s, but there are, people obviously talk about the Hippocratic Oath, and there are writings that date back literally for thousands of years talking about physicians' duties to care compassionately for their patients, to do well by their patients. And there are, again, these foundational documents in medical ethics that have a much longer history. The American Medical Association in this country published its first code of medical ethics just over 150 years ago. Most of the codes of medical ethics focused on the duties between one doctor and one patient. So public health comes along and health policy comes along, and even in medicine, there become more and more questions that are talked about at a societal level and not just at the bedside between one doctor and one patient. So for example, artificial kidneys are developed, and even kidney transplantation leads to questions about resource allocation. And there are big public debates about, should scarce resources in medicine go only to the most socially valued people or the richest people, or is that not fair? Fundamentally, we don't want a society that is organized in that way. Well, this becomes a question of ethics that doesn't quite fit in the old medical ethics model. Some of you will remember the names Karen Ann Quinlan or Nancy Cruzan, and there were debates about when to turn off the ventilator and who has the right to say, and whether there should be public policy about end-of-life care that it maybe goes beyond just the individual question, again, of a doctor and patient. There then were, in the 1960s and 70s, a lot of questions about research studies that were being done in ways that people didn't think were ethically appropriate. Tuskegee certainly at the top of the list, but there were others as well. And there were a lot of new technologies, new reproductive technologies, new genetic technologies. All of these together led to people saying, we have to think about ethical frameworks and ethical guides that go beyond the one-on-one doctor-patient. So this is where people say there was the birth of bioethics. At that time, however, the places from which bioethics grew led still for bioethics to have a fairly strong emphasis on autonomy. So bioethics talked about several principles that it stood for: doing good for people, respecting autonomy, and being fair. But as people started to develop individual guidelines, there was often a very strong emphasis on individual autonomy and the importance of respecting autonomy. So patients and research participants have the right to refuse. You can refuse that ventilator. You can refuse research participation. Patients' rights movement, informed consent in medicine and certainly in research became absolutely the norm, particularly for things that are more consequential. And the old codes of medical ethics were amended. The AMA code, for example, was amended to say things like, not only must you do good for your patient, but if in the end the patient doesn't want that treatment, the ethically right thing for you to do as a doctor is to respect that refusal. So there was this strong emphasis on non-interference. For anybody who does public health, we know that sometimes our emphasis is not only on what do you want, have I explained it well, well, if you don't want it, then that's okay, I'll step back. We have a different kind of value that we place on a lot of pieces of public health work that are fundamentally important to being able to do this work successfully. So there's a very strong value in public health on benefit to others. This whole idea of we collectively make the conditions for everyone to be healthy is thinking broadly about utility and, again, beneficence, this ethics principle that's quite different from autonomy. And justice is fundamentally important. This work dating back to the 1800s of Edwin Chadwick, of seeing that there's a difference in life expectancy between the rich and the poor, or mapping garbage heaps, is fundamentally a way for public health to say, if we don't have socially just conditions, we will never have good public health outcomes. So for people like me who care about ethics and care deeply about public health, we come to these questions of, so what's the right ethical frame for us? We do need ethical guides that can both give us, if you will, negative constraints, limits on what we can do, because there's actually this police power in every state of the country saying we can lock people up, we can close restaurants, we can kill animals. So there has to be some restraint so that we don't feel like we can go and impose laws on every single thing that conceivably could lead to a better public health outcome. An example that I often give is we're going to be talking about a sexually transmitted disease today. HIV is another big one. Gonorrhea, syphilis is still a huge problem in Baltimore. But we don't have laws that say, for example, anybody who dates on a college campus is required to use a condom or they can be locked up. Okay? It would be a really effective public health intervention, but there are other values that are important to us in addition. And so it's important for public health ethics to think about, well, what are the negative restraints? What are the limits, the boundaries we'll put around what public health really can do? Arguably, we would also want public health ethics to affirm some positive obligations as well. And again, this social justice theme is so important. And presumably, ethically, public health must do certain things. It must do certain interventions to improve the public's health. And again, arguably, must do certain kinds of things to improve conditions under which people can thrive. I'm going to present two frameworks that exist for thinking about public health ethics. And again, then I'm going to stop and we're going to focus on HPV specifically. So the first comes from an article that for people interested in this, I recommend, by Jim Childress and several other people, called Mapping the Terrain. And in this article, they outline 5 core principles or things to pay attention to if you want to think about the ethics side of a proposed public health program. One of these is effectiveness, right? Part of what public health does a lot of times is start, we don't even think of it because we do it all the time, but in certain ways trampling on people's rights, whether it's requiring vaccines or requiring calorie labeling. I mean, that seems so innocuous. I think it is pretty low infringement in the scheme of things, but there always has to be some kind of attention to, was it effective? Proportionality is another ethics theme here. It says the more infringement there is, the larger the outcome, and arguably the more confident we have to be that this outcome really will happen. Necessity. If there will be infringement, we have to say that this is the only way we could have achieved that goal. If you can achieve the same public health benefit through lesser infringement, I would like to say, obviously, it is the ethically right decision to go with less infringement for the same outcome. So necessity, at least infringement, go together. And then public justification. And this is what we in the ethics world call procedural justice. It's attention to process when we're thinking of the ethical good. And if there are things that we're debating and people don't know, there's some people in the public who think that that's too much infringement and other people think it's okay, then there needs to be an opportunity for public conversation, for public input. So I'm also going to introduce another framework. This was one that I published, but that have some very similar ideas in it. This came out the year before the other one. I have references on both for anybody who cares. So this is intended to be a very practical framework for people in public health who are, again, trying to think through, should I do that program or not? Is it okay to have this kind of infringement? Is it okay to work with only one population and not others, et cetera? So step one is, what's the goal? And again, today we're going to be talking about HPV vaccine. So what's the goal of having an HPV vaccine program, right? And in my view, the goal of the program has to be stated in terms of reduction of morbidity and mortality. Now, it may be that the particular program, like calorie labeling, does not directly in that moment lead to less obesity in our population, but there needs to be a causal chain that people can make and pay attention to that will lead to something that is a reduction in morbidity and mortality. To simply say this calorie labeling or this smoking cessation program will get, for example, fewer people to smoke is not enough in and of itself, or saying this education program will get more people to know what is healthy food is not enough if all the rest of the steps don't happen. Step two is, how effective is that intervention in achieving the goal, right? So we could all rattle off 5 things right away that we would like to be better in terms of public health outcomes. It might be less obesity, it might be less chronic heart disease, it might be less of certain infectious diseases, less injury. And how do we know that this intervention actually will achieve that? It turns out in the history of both medicine and public health, there are a lot of really great ideas that turned out to be wrong. And this is the step of the analysis that says there have to be data. And if there aren't data, then you need to study it. But you can't go ahead and impose a public health program that might have an infringement without some pretty clear data saying it does make a difference. Again, particularly if there is some kind of infringement or if you're targeting one population or the other. If there are data, then good. You know what the goal is. There are data that show that that intervention really will help to achieve that goal. Then you go on to the next step, which is, what are the known burdens? So, okay, I've now dealt with the good side of the equation. I know what my public health goal is, and I have data that this intervention, at least to some degree, will help ameliorate that. So how burdensome is it? How burdensome is this intervention? There can be in public health intervention risks to liberty, risks to self-determination, and I'm not going through all of this, but it's on the slides. Obviously, different public health programs raise these in different ways. It's our bread and butter. Nothing to be ashamed of from my view, but something that's really important to pay attention to for every intervention we might propose. There can be risks to privacy, physical risks, obviously it comes up in questions about vaccines, and risks to justice happen if there's some way in which my program would further exacerbate disparities. How can burdens be minimized? So the first step in burdens is to think through what are all the bad things that could possibly happen, particularly in the name of ethics, threats to people's welfare or interests. And then what could I do in the planning and design of my program to minimize those? And very often we do that in public health and maybe we don't even realize it. So even in contact tracing, there's a duty on the public health person to do the contact tracing. But the person in question with gonorrhea who might not want to give the names doesn't go to jail for not doing that. So the way the law is written is that the public health person has a duty to ask and follow up. But the person who's scared about giving a name does not have consequences to them. And that's a way of ameliorating some of the burdens of contact tracing. So informing people about the burdens is a way of lessening them. Confidentiality protections, applying burdens justly, comparing benefits and burdens of different alternatives. And then something that we can maybe talk about later that happens in some vaccine programs as a sort of paradigmatic example is sometimes allowing people opt-outs to what are otherwise mandatory programs. And I don't need to tell this crowd lots of pros and cons to that, but it's a way that public health navigates some of the ethics questions. Is the program implemented fairly? So the first 4 steps are sort of what are the goals, what are the good things, what are the bad things? And then we get to, is any group particularly advantaged by this? And then, of course, what we'll get to is that justifiable? Obviously, with HPV vaccine, we're targeting a very particular group of citizens of our country if we talk about the United States. Is that fair? Well, of course, there are reasons why we're targeting people in these certain age groups. But you have to ask the question of if you're targeting, why is that happening? Is any group advantaged? Is any group disadvantaged? Fair implementation is not equal implementation. So equal implementation would be if the program isn't the same for every single person, then we don't do it. Of course, that makes no sense. Fair means it's justifiable from a public health perspective, and it's also justifiable that different groups with different needs are all getting their fair share. So it's not only that it has to be justifiable, like, of course, teenagers are the ones we target, but in our broad public health initiatives, we're thinking about the teenagers, we're thinking about the babies, we're thinking about the people who are older, we're thinking about the people with orphan conditions, we're thinking about the people with the highly prevalent conditions. That's another way of thinking about fairness. This is the justice step, this step 5, and that's why I put on here also any affirmative obligation to right existing injustices. And in my view, there's this big question mark about whether public health ever ought to go beyond what I will call the narrow boundaries of public health in thinking about this question. So I'll just throw out something really provocative. Probably the biggest predictor for health outcomes anywhere in the world, and certainly in Baltimore, is education. So what if we took some of the public health budget and invested in public education? Probably not going to happen, but this is the kind of thing I mean, that is, if we think broadly about social conditions, it's like the garbage heaps, it's like our school being originally called the School of Hygiene in Public Health. Those kinds of things ultimately can have a huge difference on public health outcomes. The last step is how can the benefits and burdens be balanced, and that's where the public justification comes in. So I want to stop here and turn it over to Connie, who's going to talk about HPV, and then I'll come back for a couple minutes and talk about policy options.
Okay, I'm Connie Trimble. Thanks in advance for your attention. I'm a clinician. I take care of patients. So let me tell you some practical things about HPV. First, I have no conflicts of interest to declare. In fact, I'm just happy to still have a job. When I give a version of this talk to kids, sometimes I start this way. I ask them, how many of you have known someone who's had cancer? Raise your hand. Yeah. Okay. How many of you have known someone who had polio? This number of hands that go up is different than when I'm talking to 6th graders. But much of this is true because of vaccines. Cervical cancer is caused by a persistent infection with human papillomavirus. And although we've known how to screen for cervical cancer for over half a century, before we ever knew what the cause was, cervical cancer remains the 2nd most common cause of cancer death in women worldwide. How can I, make those 2 sentences in the same breath is beyond me. We now have a preventive vaccine. We have many ways to screen for cervical cancer. But in my remarks, I'll focus on cervical disease. But I want you to keep in mind that HPV, we now know, causes cancers at many other anatomic sites in perfectly immune competent people. And for disease at other anatomic sites, we have no validated screening algorithm. So it's actually a really big problem. I think it's one that we could get at in our lifetime. But here we go with biology. Okay, this is a slide I use for the medical students to drive home a point. Papillomaviruses are a family of viruses. They're double-stranded DNA viruses. They replicate, they have a really specific tissue tropism, so they replicate only in epithelium. And even different families have different tropisms for different anatomic sites. HPVs or papillomaviruses promote cell proliferation and survival rather than death. So they're really common. In fact, they're essentially endemic. In humans, there's 4 main groups. We think of one which causes genital warts, not so commonly cancer, another set which causes genital cancers as well as cancers of the head and neck, and then different sets completely which cause warts and skin cancers. The carcinogenic strains don't make warts that you can't even tell you have them. So here's an example of one mucosal lesions. Genital lesions, I think, is where most public awareness, and of course laryngeal lesions. On a bigger scale, from 40,000 feet, we know that 1 in 5 human cancers is caused in the context of a persistent infection. And this is a bar graph to show you the most common ones. And knowing the specific pathogens raises then the possibility of being able to manipulate a person's immune response to either prevent or treat disease. Most of the cancers associated with infectious pathogens occur in the developing world. We have viruses to prevent 2 of the most common ones, HPV and HBV. This is the HPV mantra from the point of view of a clinician. Normal cervix, we have several ways to screen. On the top panel, the pap smear, normal cells. The middle screen is a low-power photomicrograph of what the histology looks like. And you can also directly visualize cervixes. Now then, just about everyone gets infected or exposed pretty soon after they start having sex. Having said that, like other viruses that cause a lot of human disease, one of the reasons it's so common is because it doesn't do a darn thing to most hosts. And so you can't tell that you have it, you have no symptoms, and it takes quite a long time. It can take quite a long time for your immune system to clear it. So in the interim, you touch somebody, and so it's passed on. Having said that, in the percentage of people, maybe 10% we think, who can't clear or have a persistent HPV infection, that's the risk factor for the pre-invasive lesion, or CIN3. But we can screen for that also. And on the top panel is a pap smear. We can also do HPV testing. The middle panel is what the histology looks like. And again, we can directly visualize lesions. For those of you who have the biology gene, there's a very high nuclear to cytoplasmic ratio in the abnormal cells, and the screening direct visualization is not really high tech. We put vinegar water on the cervix, and what that does is it dehydrates the surface cells, and abnormal cells have less glycogen, so they dehydrate faster. So then you look at it, and the abnormal cells turn white. We think CIN3 is the goal. Identifying CIN3 is the goal of most of our screening programs. We think that all invasive cancers arise from untreated CIN3s. Having said that, this continuum from normal to CIN3 to invasive cancer takes years and years and years, 10 years. So from a public health perspective, there are many, many options for preventing cancer. This is data on American adolescents. I made this slide before the last election. I have not been able to stop using it. HPV exposure does happen early and often. These are data on American adolescents self-reporting the onset of penetrative heterosexual vaginal sex. And I think there are two take-home messages. One is that boys and girls track pretty much together. And the other is that this surprises me, even though I've been doing this for a while, but by age 19, 3/4 of our young people report having had at least 4 partners. You betcha. So all of these factors add up to we think that the lifetime risk of infection at least once with a high-risk HPV type is well over 80%. This is data that was published last summer on rates of uptake. You know, the vaccine, we think it would be a great way to prevent disease, but rates of uptake are disappointingly low. I have to say that, I'm sorry to say the disappointing part, but amongst eligible young people, the rates of uptake are less than 50%. And we did a study here in our system. You'd think that somebody who wanted the vaccine and got their first vaccine, well, okay, they actually really want the vaccine and they've chosen to get it. But the rates of completion in our system amongst vaccine initiators is 1 in 4. And I mean, those are people who got 1 out of the 3. So that raises a different kind of burden, I think, because it's our public penny that's paying for these really, really expensive vaccines. And if it's not going to be administered effectively, that adds more to the cost. Mind you, we need to maintain screening algorithms for a long time, too, because we don't know how long the benefit will last. The flip side, the cumulative risk of CIN3, pre-invasive disease we call these older women now, but that's over the age of 30. HPV screening is another way to potentially identify risk. With a one-time positive test for HPV 16 or 18, the cumulative risk for disease in women over the age of 30, you know, you don't want to be on one of those red or orange lines, basically. But having said that, okay, we have ways to screen for disease. How come people still fall through the cracks? We did a study here to try to figure that out. There are many steps a person has to go through in order to have disease identified. Okay, maybe they don't come in for screening. Maybe people don't come in for screening, and that's how come they get disease. Or maybe they come in and they have a healthcare visit and we don't screen them. Or they get screened and they have an abnormal test. Well, then they have to come see somebody like me. And they don't want to do that because I basically do everything that the dentist does, but down there. Okay, I can understand that. Or they come see me and they have an abnormal result and they run away again and they don't get appropriate therapy. So there are many ways you can see in real life that a person could be diagnosed with cervical cancer. Okay, if you had to, which way do you think is the most, is the reason that women in our system get cervical cancer? They don't get screened? The first one or the second one? You're right. We looked at all the new diagnoses of cervical cancer in our system. These were people who were, they had jobs, they had insurance, they had transportation, they had telephones, they had sort of low-grade medical issues for which they had seen a primary health care provider in the 3 years preceding their diagnosis. I mean, you know, a little hay fever, a little sugar, a little depression, and we just didn't look. So this is a new soapbox that I have when I talk to the general internists. If you don't want to go down there, just send them to us. This graph is also relatively new. We have an increasing understanding that HPV disease, the incidence is increasing in other anatomic sites. I think it's safe to use the E word, epidemic, in terms of HPV disease in the base of the head and neck. HPV is causally associated with 25-30% of squamous cancers at the base of the head and neck. The incidence is increasing and will likely surpass the incidence of cervical disease in the developed world. As you can see from this graph, the incidence in males seems to be higher than in women, and I don't think the biology of that is very well understood yet. But the point I want to make is that screening is a luxury of a high resource setting. We in the United States, we spend $6 billion a year chasing down abnormal pap smears. So in North America, where we have some money to spend on it, a diagnosis, two-thirds of women who are diagnosed with cervical cancer are diagnosed early enough so that we can cure them. But in a low resource setting, a diagnosis of cervical cancer is essentially a death sentence. This is not an electoral map. This is a map of the incidence of mortality rates in the United States of cervical cancer. And you can see it's really geographically, the geographic distribution is really clear. It's up and down Appalachia and along the Mexican Tex-Mex border. Okay, I'm going to finish here with some slides about the differences between preventive vaccines and therapeutic vaccines, even though I'm preaching to the choir. So the idea behind a prophylactic vaccination is that you want to... Infectious pathogens generally have specific receptors on their cellular targets, and the idea behind a prophylactic vaccine is to generate high enough levels of neutralizing antibody that basically recognize germ of choice, so that if your system is exposed to the germ, they glom onto it and basically just prevent the germ from entering the cellular target in the first place. Now then, for the rest of us who have all already been exposed to HPV, the prophylactic vaccines don't offer, we can't be protected from them. So what we work on across the street is immune therapies. In the case of HPV disease, the relevant biological event in high-grade lesions is that the HPV DNA has integrated into the host genome. Eventually, though, viral antigens will be exposed on the surface of infected cells. And so what we do is we try to devise strategies to make T cells that will recognize viral antigens and kill infected cells. The strategies for validating preventive as opposed to therapeutic vaccines are really, really different. For prophylactic vaccines, again, the idea is to inhibit infection in the first place. This requires huge test populations because you have to identify negative or naive populations first. Require many, many years for validation. What's your endpoint going to be? And the preventive vaccines have no therapeutic effect. Therapeutic vaccines, on the other hand, it's a different strategy. It's lesion elimination occurs via a T cell response. Antibodies are not germane. You can do this in relatively small test populations, i.e. somebody who's infected or somebody who's got a measurable disease, and viral clearance is a rapid, pretty quantitative endpoint. When I went to the FDA to get my first IND for immune therapies, they said, why do you want to make a therapeutic vaccine? We already have, you can cure disease. And I said, okay, well, if I told you that you had a really common infection in your parts, but don't worry, that a relatively trivial surgical procedure could cure 90% of lesions, and this is what your parts looked like after I got done, what would you think? And the body language was really interesting, because they all kind of went like this. I said, we think therapeutic vaccines are a great idea. This is my last slide. This is the incidence of polio in 1988, which I think is not very long ago. This is what the cervical cancer map looks like now. And with concerted efforts at vaccination, this is what it looks like in 2010. And I wonder if we can make HPV disease a history lesson for our kids.
Okay, so totally great. And I am going to just maybe kick off the discussion part of this by raising some of the policy and ethics questions that have come up around HPV preventive vaccine, and apply a little bit of the thinking from the first part. So, people often talk about should vaccines or any other public health program or interventions be mandatory or voluntary? And as a broad brush distinction, that's okay. We can actually split hairs and categories a lot more than that. I have put 3 categories on here, which I think are relevant to the kind of public health programs that people have been talking about for HPV vaccine. So the first is called mandatory, which actually people, again, who like to be analytically perfect, might call conditionally mandatory, which is the way most of our vaccine policy is, which says something like, if you want to go to school, public school, most other private schools, if you want to go to a lot of day camps, then you need to get the vaccine. It's not actually, if you don't vaccinate your little kids or your teenagers, you get put in jail for not vaccinating them, but you can't participate in most things that most people, in a lot of things that most people want to participate in. So even though we say childhood vaccines are mandatory, they are what I would call conditionally mandatory. It's fine to use the label mandatory. I do it myself, but I want to emphasize that it's another way that these exceptions are built into our policy, and maybe for some people in the name of ethics. So one option for HPV would be mandatory, to pass something that is similar to the way we have policies for a lot of our other vaccines, and say, for example, in order to enter middle school, there are now some other vaccines like this, your kids have to get HPV. Another is routine. And what that means is that it's not mandatory, but every time your kid goes for the checkup when your kid is 11, the pediatrician says, okay, here's the panel that we give at age 11. In the same way that when your kid was 1, they said, here's what we give at 1, they would now say, here's what we give at 11. Which is different from permissible, where they might say, hey, there's this vaccine that's out there. Let me talk to you about it, pros and cons, and you can go home as a family and talk about whether you want it and come back if you decide you want it. Both of the last 2, strictly speaking, are voluntary, but as you can imagine, the uptake from routine is much, much higher than the uptake from the sort of what I'll call permissible. Now, we will get into why the CDC would move from saying that something is acceptable or permissible to doing what, for example, it just did a couple months ago with HPV vaccine for boys, which is to kick it up to the routine category, right? When the CDC thinks that we are now at a point in public health and in data for the intervention that all of the scales are tipping much more to the benefits than to the concerns. This is when public health and the CDC as our federal public health agency say, time to make it routine. But there are these questions with every new intervention, and certainly with HPV, and there are states that have been debating mandatory as well. There's another question, should you have the same policy for girls as for boys, and why? And we can get into that more in the Q&A. I just have a couple slides on what ethically can justify a mandatory program. Because again, in public health, we decide that certain things absolutely should be mandatory, and childhood vaccines I think are one of the paradigmatic example. I love Connie's history slide, and that's an example of, in a lot of ways, at least in this country, something being mandatory and part of what you get from that. So part of what justifies something being mandatory, thinking back to that framework I had outlined, is how big a problem is it? Is it a problem? Is it a big problem? And when we say how big a problem is it, we usually mean the magnitude and the severity. Is it affecting a lot of people? And when this thing that we're preventing affects them, can it be bad? Do the less burdensome alternatives work? And for that, we might say, well, instead of mandatory, if it were just routine, or instead of routine, if it were just permissible, would we get as much coverage? If it turns out we would, then you don't really have to make it mandatory. I mean, truly, there's no reason to make something mandatory if everybody's going to do it anyway. If people aren't going to all do it anyway, that's when these questions emerge. If people are not all going to do an uptake of this without it being mandatory, who are the people who end up getting it, and who are the people who don't? And is there anything systematic about the people who end up getting a vaccine and people who don't? I would love for maybe Connie to say something about, of those 25% of people who ended up following through with all of their course of HPV vaccine versus the 75 who didn't. Were they different from each other? I mean, certainly some national data I've seen says that people of color and people of lower SES are more likely to be the ones who aren't following up. And that has really important implications when we start to debate these policy things. It's not just that some people choose to, some people don't, but if systematically it is poorer people and people of color who are either not starting to get HPV vaccine, or are even before that not getting their pap smears, it raises a whole different kind of question about whether we should change the way we recommend or make mandatory any kind of vaccine. And then how burdensome is it to be mandatory? So why would there be arguments for mandatory? Well, HPV, the vaccine works, right? That data step, it's there, at least for 5 years, and at least if you can believe the kinds of immune markers that are used. It seems safe, not very burdensome. There's 18,000 HPV-related cancers in women per year, 7,000 HPV-related cancers in men per year. This is just in the United States, obviously extraordinarily larger globally. And it's really hard to reach adolescents. So if you look at the likelihood of anybody coming in for their yearly pediatric exam, it just starts to dwindle by the time kids enter middle school. And then there is this idea that I was just talking about promoting justice. And it ensures that all girls and now boys are protected if it's mandatory, whereas systematically it turns out that they're protected in ways that we may find where the differences may be troubling to us as a society if we don't. Why against mandatory? Okay, civil liberties. There are people who don't like mandatory anything. There are people who will vaccinate their own children and don't want laws about it. And it's a rational position, right? We have a presidential candidate who is espousing that position. It's a libertarian view at its extreme. But in public health, again, with my condom example is an illustration. There will always be things where some people say, look, that's ridiculous, don't make it mandatory. And to what length can public health go for something that has data behind it, that will protect the public's health? And is this an example where we're going to vote yes or we're going to vote no? There has been with HPV in particular, because HPV is transmitted sexually, an enormous amount of dialogue about whether we're sending a message to our kids that we're now giving them at the age of 11, our little girls and boys, a green light to go be sexually active. Okay, I hope not, but there is a legitimate question that we have to follow up with empirical data collection about whether the kids who get an HPV vaccine are in any way more likely to initiate sexual activity earlier than the people who don't. Again, there have been studies that seem to suggest so far the answer is no, but given how much that's part of the debate, it's absolutely something we have to get data around. Is there any other kind of public health backlash from perhaps these kids feeling protected? So maybe a message has gotten through that it's a vaccine somehow related to sex. Okay, that's really bad health education. But to the extent to which that message has gotten through, does that mean they're less likely to use condoms? That all of a sudden we've got less cervical cancer, but we've got more teen pregnancies? All this stuff is the kind of thing that people use as arguments about mandatory. They're really important questions. Of course they're important. And, being trained the way I do, I say, right, we got to collect data on that. Of course, there are a lot of things where if they were true, it would make you consider a policy differently. So you got to find out, are they true or not? in the end, not that fruitful to keep saying, but if that happened, it would be really bad. Well, if that happened, it would be really good. Fine, let's see what happens and actually collect the data. Some people say that it's overreaching to require it for all. Just vaccinate those who are at greatest risk. Maybe just vaccinate all those girls we're figuring out are never getting the pap smears. Well, first of all, we are learning that HPV is protecting against much more than cervical cancer. And secondly, we have learned, and this is why some vaccines are now given in a very different way, that I put up Hep B as an example. In certain ways, you really just want to start hepatitis B vaccine before people become sexually active. But because it is so hard to reach middle school kids, babies are now vaccinated with Hep B. It's not because people think they're at risk when they're 1 and 2 years old. It's because it's a time you can catch them. And that becomes, again, relevant. Safety concerns, is it too early to make something mandatory? I will say that I certainly know people who are very big proponents of HPV vaccine, who are themselves saying, I think it looks great, but of course we're going to know a lot more in 10 years, and is that when we should make it mandatory rather than now? Backlash at industry tactics, I only have that up there because, as some people know, when the vaccine was first approved for girls, there were some big policy pushes in a couple states in particular for there to be bills passed that made it mandatory within those states. And it turns out, it was later revealed in a way that probably was really counterproductive for public health, that those policy pushes were funded significantly by an offshoot group funded by the manufacturers of the vaccine. And it made people very suspicious, understandably, about, oh, do you really care about these girls, or do you just want to make a profit? And that whole conflict of interest question soured people a lot to some of the debates about mandatory. It's also expensive. The price has come down since it was first approved, but it's expensive, and people get into these trade-offs. Public health is underfunded. Again, I don't need to tell this crowd. And so is that the best way to spend money, is something that some people say when they wonder about this. I think that this may be, yeah, that's my last slide. Just a couple other questions to throw out about HPV vaccine in addition to the mandatory versus routine or permissible policy options. And that's what type of messaging. So let's say, you're in charge of developing the HPV vaccine materials for all the pediatricians to hand out in their offices, or for the public health department to distribute. What do you want to say? And do you want to say, we have a new cancer vaccine, boys and girls need to get it? That's one option. Do you also want to say, or do you instead want to say, we have a vaccine that you have to get before you start sexual activity? So there are ways in which both of these are true, and the messaging comes across really differently. And I think it's a really important question to both think through what's most effective, and also, this is something that I actually love to think about, when we do health education messages, how much detail do we have to provide ethically? I certainly will put out there that my view is that a broad public health message can be very different than the individual counseling we give to people. I think it really is fine that there's a billboard that says smoking kills, even though, of course, when you start counseling someone one-on-one, you say, right, not every single smoker dies, and it's not like you light up one cigarette and you drop dead. And so the way that we do broad messaging must be honest, but it can be quite different than how we do individual counseling. But it becomes really relevant when we're developing messages for something like HPV. And then, should parental consent be required? The age group we are targeting is adolescents. And this does sort of have to do with sex. And maybe the kid hasn't been coming in for the annual exams, but is coming in for birth control. And that's a moment to catch these kids and do HPV. And for most things, we require parental consent. We do have ways in which we allow certain things with adolescents to not require parental consent if they are acting like an adult, like things like birth control. But where does this fit in? So I'm going to stop, and I think we have almost 35 minutes for questions, and I guess we're going to field some, and Molly is going to field some from the email. I want to put out there, I had told Molly that I'm personally darting out at 1:20 because I have to go to New York, but I think Connie's here till 1:30. So thank you.
Thank you, Nancy and Connie. This is the time where we are now open for questions from people from the audience. And again, if you are watching online, just click on the link and we will be able to get to those questions as well. But we'll start right here, right in the back.
Two quick questions. First of all, you talked about wanting providers intended they were seeing a nurse practitioner, specialist, internal medicine, or family doctor. And the second question is hepatitis B is a sexually transmitted disease, and there's no real controversy behind hepatitis B vaccines. Why the heck can't we do this with HPV? Is it the internet? What's going on? Like, why is this different than it was when we rolled out HPV? Thanks.
Your first question is relatively straightforward. The question had to do with, does the likelihood of getting screened depend on the characteristics of the provider? And we think it does. So one of the questions we're asking now is we're looking at how far the person is out from finishing their training as a proxy measure of. We're also looking at subspecialty.
Do you want to do the Hep B question?
The Hep B question. If I was king of the world and was in charge of marketing, I would have marketed it as a cancer vaccine.
Yeah, I've said the same thing from the beginning. I agree. So why it didn't turn out that way, I have no idea. And maybe somebody does, but I don't know.
Hi, my name is Jeff Kaplan, and I'm an internist in private practice, but I also run the Public Health Committee for MedChi, the State Medical Society. And so I think that I'd like to give a provider viewpoint. First of all, I'd like to clarify the point about internists don't do office gynecology. We don't. It's family practice and, of course, gynecologists. So as a group, we're not there to do that kind of screening. Certainly in my internal medicine residency, that wasn't part of my training. That was several years ago. I currently am not aware that it is part of the training, but I just wanted to clarify that. Right. So it's now being, internists are now doing it? Not everywhere. Okay. Okay. So I wanted to do that part of the screening, but the other thing is having to do with where the vaccine is administered. And I think that's a very important point, because if the targeted group are 11-year-olds, I've talked to my pediatric colleagues, and it doesn't appear that there are any other routine screens that get done at that age, and therefore one of the difficulties have been, and there have been studies to show that the intersection of girls coming in to the pediatrician is apparently there are like 5 lost visit options to administer the vaccine on top of what is usually not a well visit. They don't have that many scheduled well visits. So at that age, they're in the transitional age, and usually they then go a bit later to see the gynecologist. And I don't know the experience of the gynecologists if the first visit is often before initiation of vaginal sex or after. So then we have that other provider interface, and which is the most useful one to be able to have and administer the vaccine. Well, I'd like to put a different viewpoint on that, because this is where private health in the US and public health are giving too much importance to the role of private providers in administering the vaccine. So I've looked at the results internationally of the success of HPV vaccine uptake. And as you were showing, in America, the statistic is perhaps a third actually get all 3 vaccines. And at one point, and I have a study here that shows in 2008, it was like 18%. In other countries, Belgium was 44%, in Australia, 66%, and in the UK, it was 80%. What did the UK do that was so much more successful than we are and than we will ever be if you come to entirely rely on the provider community to vaccinate. And what they did is they gave it in the schools. And that's the important thing, is that if we want to have a successful way of administering this vaccine to a huge number of girls who are at risk for cancer, we have to think of having school-based delivery of the vaccine. 90% in the cohort of 11-year-olds in England got the first vaccine. 80% got all three. That's incredibly successful. And so we need to really think that we need to try and have mandates. I'm entirely in favor of mandates. I find that the arguments that this, for example, that might provoke a backlash against of anti-vaccinationists, we should be strong enough to be able to make those points. But we do need, I think, to look at school-based programs. It's important. This is a very expensive vaccine. This costs $300 to administer all three vaccines. I'm a primary care physician. I'm an internist. I have to put out, myself, $300 to buy the vaccine, and then I hold it, and then I have to administer it in the hope that I'm going to be reimbursed. Well, this is way too much. And if you look at how much it's going to cost primary care providers to put up front to buy this, to be able to cover enough patients, it's not going to happen through the primary private provider community. And of course, I'm sure that some of my colleagues would not want to hear that message because they like to think they can do this. The answer is no, you can't. And if we're going to devise successfully a program in the US, it should have a major component of being school-based.
I feel like that's mostly a comment.
Yeah, okay. Any other questions? Right here in front, if you could just please wait for the microphone so everyone online can hear your question.
Hi, my name is Megan Harris and I work for JPIGO. I work on international VIA screening programs and an HPV study in Thailand and Philippines. And you spoke a little bit about the mandatory versus voluntary situation in the US. And I'm just wondering, can you put that in the context of an international developing country context in terms of where cervical cancer, the burden is probably the highest? I was wondering if you could just talk a little bit more about that.
So in the largest sense, I think that the ideas are the same, but the way you answer it is, of course, going to be completely dependent to what the finances are locally and what the epidemiology is locally. So the burden is so much higher in other places. And I think what a lot of us would love to see is a rollout of a lot of HPV programs. There's a huge question about whether that comes through a donor base or whether it comes locally. If it comes locally, it's hard to believe it's going to make it very quickly given the cost and given the extraordinary competing priorities. And there are things that still aren't being done. We all know that don't cost very much and would make a big difference, and again, they're still not being done. And so it depends a bit if we look broadly or if we look narrowly. I mean, I do think that figuring out a way to get the vaccine far more accessible would be, I'm just speaking personally, the highest ethical priority before even getting to the question of whether it's mandatory or voluntary. It seems like the first thing that's important is making it available and seeing how the heck that can happen I mean, I sort of feel like the last comment ultimately was a systems comment, and to think about what are the systems and in part what are the messages. And I sort of feel like then down the road start to think through the mandatory question.
I was wondering if there's a difference in funding streams if something's mandatory versus permissible, and if, you know, making it mandatory would eventually drive down the cost and make it more accessible.
Yeah, that's a great question. So the big difference is between whether it's routine or whether it is voluntary. So when it's so it depends a bit on the particulars, and we're talking more about vaccines. But once it gets recommended, then it also goes in a category where it is where a whole bunch of payment programs kick in, and it gets included in the portfolio of things. It is also true that a state cannot require something to be mandatory without figuring out a way for people to pay for it if they can't pay for it themselves. But I think with vaccines, you hit that payment threshold before you get to mandatory. There are vaccine. Well, HPV is a good example. Right now, HPV is not mandatory in Maryland or in most other states, and it is paid for through all these vaccine for children programs, et cetera. So my point is that there's the steps that it takes to get a vaccine paid for through government programs and for insurance companies to start in parallel covering the same things happens before you even get to the mandatory threshold.
Okay, we do have some questions from our online audience, so I'd like to get to those for a minute. First is, I guess either for Nancy or Connie, what do you feel would be an effective way to increase Gardasil vaccinations in the MSM population?
You know, one thing that occurs to me is that the more routine the vaccine is for boys, it's a relatively recent change, that recommendation from the CDC that HPV vaccine not only be available for boys, but that it now be routine for boys. And I think one thing is the hope that it becomes a more universal message for boys that all boys should be getting this. And obviously that then will be protective for boys who have sex with boys, men who have sex with men. There certainly can be some pretty important messages in targeted health education. This is not the first time that public health has tried to do messages that target men who have sex with men, and using a lot of the same channels seems really important.
Sorry, I got stuck on the men part because, like any of us who are older and have already started having sex, it's the preventive vaccine it's not preventive anymore.
Yeah.
So boys.
It's relevant for the boys, yeah.
It's for boys.
Okay. That's another question asking, not all of the cases of HPV-related cancers are caused by the subtypes covered by the two different vaccines. Is there any concern about ecological replacement?
Yeah, that's a question that comes up fairly often. Obviously, we're getting data, but I think that the biology of HPV is that it's really indolent, and the likelihood that a strain that's genotypes that don't already cause disease would mutate to cause disease, I think that's really low, actually. So I know that vaccines are being developed to cover more genotypes. Having said that, and that coverage will depend on the epidemiology in different populations.
Okay. And this is actually more a comment from a practitioner in Madison, New Jersey. I believe that healthcare by internists should include recommendation for appropriate cervical screening if it's not being done in their office. And I used nearly 200 doses of HPV vaccine that I received through ARRA funds at no cost on a college campus in our municipality, going to where the students, offering at no cost to the student and having standing order to administer, contributed to the success of the effort. Thank you. So, yeah, question right here.
A couple of comments and a question. any new data about the duration of efficacy of the vaccine? You mentioned 5 years. And what are you going to recommend in terms of pap smear screening, when to begin that? Because if the efficacy is only 5 years, what will happen thereafter? That's number one. Two, I gave Dr. Kass a copy of an article, but I'd be interested in your comment on was sort of diatribe against HPV vaccine, which is terrible. The second one is there's a lot of discussion now about including HPV in Gavi in the sense to posit differential pricing of HPV vaccine. So the idea that it costs $300, very few developing countries will be able to afford a vaccine for $300. But there's intensive discussion now about the possibility of reducing the price of the vaccine. But I'd like to emphasize the point you made. It is not only the price, it's the delivery systems that really represent a major block all over the world. Having said that, I think it is barely fatuous to point to say that we must improve the delivery system before we give the vaccine. Well, life doesn't work that way.
The pap smear question.
And how long it will last?
We don't know. We're getting data. Now, the screening recommendations include I think for non-vaccinated, just across the board, not to start until age 21 or the onset of sexual activity. And if a person has had sequential normal PAPs, it's okay to space out screening. In women who are over the age of 30, I suspect the screening recommendations will change to doing HPV testing, and a person will have to have sequential positive HPV tests with the same strain before being flipped to more intensive screening. But that's a really big question in terms of cost to society and how long we need to maintain screening. And it's very important in terms of education to tell our patients also when they do get vaccinated, they must continue to get screening. And I wish I could tell you at what interval, but I don't know the answer to that.
Okay, do we have any other questions? Yeah, all the way in the back.
I actually have two questions. One is that over time and in the future, would it be possible that this could be given as a childhood vaccines, like a lot of the early ones, with subsequent boosters, kind of like you do with a tetanus booster? Because another aspect that hasn't really been discussed here is issues of childhood sexual molestation and abuse. So pretty much the discussion has focused on consensual sex of teenagers, but I don't know the statistics of how common it is, but sexual abuse also cannot be ignored.
It seems like it seems like the question about whether it could be given in infancy will emerge the longer we have data about the length of protection, I would assume.
Are there any plans to do the studies earlier?
Like safety studies earlier? I don't know. Do you know?
I'm not aware.
Okay. The other question I had was in terms of your screening, you're looking at your cheese slide. Are there any I guess in development, any self-administered types of screening tools? For instance, like for STDs, you can have patients go to the lab and do a urine for gonorrhea, chlamydia, or in the SHARE study, some of the things that they're doing are doing mouthwash gargles to screen for oropharyngeal abnormalities and doing pap smears of those. Is there any kind of equivalent in development for cervical abnormalities?
Well, I think there's data being gathered in terms of efficacy and accuracy of self-screening for HPV. I think one big problem with a lot of the screens that we have is they very much over-identify risk. So that's the flip side. And an example I'll give you is PSA. If somebody's prostate-specific antigen goes up, yeah, they're probably at risk, but then you do stuff and you do stuff and you do stuff to them, and it's very expensive, and it very much over-identifies whether somebody's at risk. If you were to draw a Venn diagram of somebody who had an elevated PSA or somebody who had a positive HPV someplace, the fraction of people who had a positive test who are actually at risk would probably, I mean, it would be less than 5%. So we do need to identify better predictors of risk for disease. It's possible to put a Q-tip someplace and find HPV, but whether or not that actually identifies somebody who's at risk for disease, it's not linear.
We do have another question online. I think I had heard you say that the vaccine is good for 5 years. Does that mean that the teen will have to repeat the vaccine after 5 years, or is there a booster?
Getting data. Yeah.
I should really let Connie answer this because this is more her world, but my understanding it's just simply how long the studies, the follow-up has been done. So I think, the hope is the longer people are followed and show that they still have protection, the longer we'll know the vaccine lasts without the need for a booster, but I think the data are being collected.
Okay. And do we have any other questions here? Yeah, all the way in the back.
I just wanted to say it was a great opportunity to be able to talk to it, to listen to this. And I think that it does highlight the need for a lot of activism around education for the need for HPV vaccination and, of course, screening. We're going to have to get a lot of education out there. I understand concerns about thinking about mandating before the general public really knows about this. But then again, we've ceded the floor to some of the anti-vaccinationists on this already with what happened in Texas, where Governor Perry went back on his efforts to mandate, well, it was mandated. He mandated it, but then the Texas legislature withdrew the mandate. So we need to work on a lot of education. I also wanted to highlight again, from the provider point of view, my point in trying to say that the individual provider is maybe not and it currently is the only source of vaccination, either in the public or the private sector, is that our primary care resources are being quite strained in the U.S. And so to build a program on something that I can tell you is really struggling. I can tell you I'm probably an obsolete beast being in solo private internal medicine practice because it's not viable and we're all going to have to join groups. I think it's an important thing that I hope I was able to communicate. And again, as a public health issue, this should be taken up more by public health providers. Thanks.
Okay. I think that wraps it up for today. I really want to thank once again Drs. Connie Trimble and Nancy Kass for an excellent presentation, and thank all of you for coming, and we hope to see you again next month. Thank you very much.